In this abstract, I will present patterns and number of dissections with atherectomy versus flex VP and IVUS assessment. These are my disclosures. I want to thank my contributing authors listed on the slide from the Midwest Cardiovascular Research Foundation in Davenport, Iowa, United States. So dissection nut plaque compression creates the lumen post-angioplasty. Intentional dissection optimizes the lumen during vessel prepping for subsequent planned therapy. Severe dissection per the NHLBI classification, typically C and higher, and dissections involving the adventitia, typically in the eye dissection classification as C1 or C2, are likely to be associated with worse outcome after angioplasty. The Flex VP system is a vessel prep device that consists of a control handle, a flex shaft, and a treatment element that consists of 3 protective skids, each with an atherectomy mounted on the proximal end of each skid. It's designed to create multiple longitudinal controlled depth microincisions across the entire lesion length in infrainguinal arteries with the intention to alter vessel compliance. A maximum pressure of approximately 1 atmosphere controls the microincision depth performed with a retrograde pullback. Vessel prep is important prior to definitive treatment of complex fem-pop arterial disease. It reduces dissections, bail-out stenting, and possibly preserve future therapeutic options, improve efficacy of drug-coated balloons, and may improve overall outcome of patients. We evaluate differences in dissections between atherectomy using predominantly the jet stream and the Flex VP using intravascular alternate. Data from the eye dissection study that involved 15 patients, mostly jet stream atherectomy with 13 patients and the Arian laser with 2 patients, and the Flex eye dissection study that involved 20 patients were compared. Both studies were prospective, performed in a single center with consecutive enrollment of patients with femoral popliteal arterial disease. Both had core lab evaluations of dissections depth and arc using the eye dissection classification. Both studies involved femoral popliteal arteries and included de novo and restenotic lesions, non-stent restenosis. The eye dissection grading system takes into account the depth and the arc of dissections. The depth of the dissection is labeled as A, B, and C for intimal involvement, medial involvement, and adventitial involvement respectively. The extent of dissection or the circumference takes into the account the arc of injury of less than 180 degree and it's labeled as 1, or the arc of injury of more or equal 180 degree and it's labeled as 2. Therefore, this grading system presents itself with 6 grades: A1, A2, B1, B2, and C1, C2. The lesion length was shorter with the Flex VP compared to atherectomy, but the treated length was the same. IVUS scanned length and the presence of severe calcium were also similar between the 2 cohorts. The number and patterns of new dissections showed fewer dissections after the Flex VP alone versus atherectomy, 14 versus 46 respectively. Post-adjunctive PTA following the Flex VP or atherectomy showed more type A dissection, i.e. involving the intima, with the Flex at 31 versus 12, and more type BC dissections involving the media and adventitia with atherectomy. Therefore, more deeper dissections were seen with the atherectomy. There were no differences in the arc of new dissections between both modalities following angioplasty. We conclude that the Flex VP and angioplasty yielded a more favorable pattern of less severe dissections than atherectomy, predominantly the jet stream, with deeper dissections seen post-atherectomy. This suggests that the Flex VP system may be less traumatic as a vessel prep system. The clinical implications of this finding will need to be further explored. Thank you.